El ejercicio es clave para la salud física y de la mente. Nelson Mandela. Se reconoce que el ejercicio produce beneficios, sobre todo en enfermedades cardiovasculares, osteomusculares, metabólicas y que puede mejorar el estado físico en general por medio de la prevención y promoción de salud. Algunas preguntas al respecto son: ¿cuánto ejercicio? ¿Qué tipo de ejercicio? ¿Cómo evitar lesiones? ¿A quién acudir en caso se presenten? ¿Acaso el ejercicio se debe formular como si fuera un medicamento para definir la dosis, tipo, duración y frecuencia? La respuesta a estas preguntas la tiene la medicina del deporte y los 3 invitados estelares que tenemos el día de hoy, que son especialistas en medicina del deporte. De parte de las autoridades de la Facultad de Ciencias Médicas, el decano en funciones, el coordinador de la Unidad de Apoyo y Desarrollo Estudiantil y de parte de la Clínica Médica, es un gusto presentar al doctor Tim Meyer, médico especializado en medicina deportiva y preventiva, y a la doctora Susan Cruisinga, médica de emergencias, y de quienes leeré un resumen de su hoja de vida. El doctor Tim Meyer pertenece al Instituto de Medicina Deportiva y Preventiva de la Universidad de Saarland, Alemania. Entre sus áreas de interés está la medicina deportiva, la fisiología del ejercicio, medicina interna, aspectos médicos del fútbol, mediciones de intercambio de gases durante el ejercicio, estudios longitudinales para optimizar el entrenamiento preventivo, el deporte como terapia de enfermedades crónicas y fatiga inducida por el ejercicio y procesos de recuperación. Entre los cargos y funciones que el doctor ha desempeñado están médico del equipo de la selección alemana de fútbol, editor en jefe de la revista de Ciencia y Medicina en el Deporte, redactor jefe de la revista Science and Medicine en Fútbol, profesor adjunto de la Universidad de Tecnología de Sydney, Australia, miembro del Colegio Americano de Medicina Deportiva, presidente del Comité Médico de la Unión de Asociaciones Europeas de Fútbol, presidente del Comité Médico de la Federación Alemana de Fútbol, presidente del Grupo de Trabajo Profesional de Fútbol de la Organización Alemana de Fútbol League y miembro del Comité Médico de la Federación Alemana de Deportes Olímpicos, miembro del Consejo Científico de la Asociación Alemana de Deportes y Medicina Preventiva, y también es embajador de Saarland. La doctora Susan Cruisinga, médica de emergencias, es jefe médico de urgencias en el Hospital de Gelderse Valley, Países Bajos, es miembro del Consejo de Vigilancia de la Institución Asistencial Carinova y también es directora y empresaria de MedSport Colombia. Se especializa en la supervisión de fusiones y procesos de colaboración en salud y bienestar y ha brindado apoyo estratégico a hospitales y también consultorías. Para mí es un gusto dejar con ustedes a los doctores, en especial en este momento al doctor Tim Meyer, quien a continuación le doy la bienvenida y agradezco su valiosa presencia el día de hoy. Gracias, doctor. El tiempo es suyo.
Thank you very much. I'm sorry to be unable to talk to you in Spanish, but as you all know, the language of science is not German, it's not Spanish, it's English. So I will talk in English. Second point, Susanne and I, we both want to make this as interesting for you as possible. I brought some slides. We do not necessarily have to go through all of them. If you have questions, just show up. And I will try to leave about 30 minutes for discussion afterwards. The presentation as it stands is that one, yes, that one is much longer, so I will skip some slides. But if you're interested in one of the topics in particular, just tell me, then I go into more details. Okay, can I do that from here? Yeah. Okay, so I entitled this Challenges for Football Medicine because most of my professional work is in the area of medical care of football players, and also the research is reflected by that. And first of all, a few words about myself. I have been introduced already, but some more details. So I went to medical school in Germany, and partly overlapping with that time, I made my master's degree in sports science as well. But now I'm a full professor for sports and preventive medicine at a university in the southwestern part of Germany. The city is called Saarbrücken. It's not so large, but you may know Luxembourg, and it is also very close to the German-French border. So when I'm at home, it's just 5 kilometers for me to drive into France. Based on this quite extensive work in football, I have become the chairman of the medical committee, German FA and UEFA, which has already been mentioned, team physician since 1999, but I have retired 1 month ago after 21 years with the national team, and maybe now focus even a bit more on science, which is reflected already by my activities in 2 journals. One of them is JSAMS, an Australian journal, Journal of Science and Medicine in Sport. And the other one is Science and Medicine in Football, which is very much focusing on the sport of football, but on all codes of football. So if you all know, if you go to the United States and say football, they understand American football, and they say soccer. So American football, Australian football, rugby, all that is part of this journal as well. Our institution has 6 physicians, 4 sports scientists, a lot of other staff members, and in general, we are an outpatient clinic. We take care of our athletes, we take care of other athletes from other centers, and we have an Olympic training center 100 meters away, which focuses not on football, because in Germany, football is not part of the Olympic training center system, because it's so professional. And the Olympic Training Center where we are focuses on triathlon, badminton, wrestling, track and field, and some other sports. We are also taking care of some regional teams, and more interesting for you possibly, we have to do some teaching, of course, at our university as well. And we have a bachelor's degree, which is taught in German. We have also a master's degree, which is taught in German, and more interestingly, we have an international Master of Science, which is called High Performance Sport. So this is completely taught in English. And then we have an international PhD program, which is entitled Science and Medicine in Football. So within that program, all projects are in the world of football, and always in the end of October, we announce the new scholarships. So for those of you who are interested in that, it might make sense to have a look at our website at the end of October. However, we also accept other scholarships over the year. It happens frequently that we have other students starting their projects with us. And finally, research. This is something that I will reflect upon a bit later. At home, we try to have 30% of the work in research, 30% in teaching, and 30% in patient and athlete care. However, most of the time, patient and athletes care is a bit more than that, but it depends a little bit if you were in term or off term. Right now, we don't have a semester. We have the winter break, and the semester restarts in mid of April. It goes until the end of July. And the winter term in Germany goes from mid of October until mid-February. And maybe interesting to note, sports medicine and doping controls are 2 different things, so we are not responsible for any doping controls. And finally, about the international orientation of our institute and of our university. I mentioned already that we have these 2 programs, and on top of that, we regularly invite international speakers for having a presentation with our students, and we do that about 4 times a year. It might be interesting that Germany is a country, like many other European countries, that doesn't take tuition fees. So for any student in Germany, there is no fee. Of course, you have to pay for your costs of daily life, but not for the university. We have some PhD students doing their projects right now, and you can see from this list that they come from different areas of the world. So Monica Duarte from Mexico, and then we have Croatia, Serbia, South Africa, of course, Germany and Iran. At this point of time, we also had some international students from Australia, from the Netherlands, and others. And the projects that you find here are all around football, because within this program, you must have your projects with topics within football, and it also reflects what we have done over the last years. So now this is enough about our institution, and maybe a little bit about medical challenges in football. And this also reflects my perspective from the chairman of these two committees, because this is exactly what we have been dealt with over the last 5, 6, 7 years. So by far, the most important topic has been heading and head injuries, because there are some indications that the accumulation of these head injuries or heading may lead to neurodegenerative disease in later life, like suicidality, like depression, like cognitive impairment. I don't say that's clear already, but there are indications that this may happen. We have, of course, always to deal with injuries, and the question that is posed to us is frequently, have there been changes in injury patterns because football develops? For example, because it becomes faster, or because the fixture congestion becomes higher. Over the last 3 years, like in your country, I guess, COVID-19 was, of course, a big topic. So infection management and sudden cardiac death. SCD stands for sudden cardiac death. You may all know that, no, it was in 2021, Christian Eriksen, the Danish player, suffered a sudden cardiac arrest on the pitch. So it was on TV. And that, of course, alarmed many in the FAs, many in the federations, and it was asked, are our programs good enough? Should we have detected that before? And with the rise of women's football over the last years, particularly with the last World Cup and also the last European Championship, which was highly successful, played in England, we have some topics which are related to women's football. And finally, environmental changes. We all face that. The best example is probably the heat. So do we have to produce something to better manage the heat? Matches in the heat at 35 degrees, are they acceptable from a medical standpoint or not? Now, I'd like to go into some of these topics a bit more deeply, but once again, interrupt me if you think something's missing or something should be discussed in more detail. So first of all, heading and head injuries, and probably the most prominent study that has been published around this comes from Glasgow, the so-called field study, and it has been published in the New England Journal of Medicine, which is quite unusual for a topic out of football. So in the New England Journal of Medicine, you can publish something like a new vaccination against COVID, but not necessarily something against something in football. So what did they do? In Scotland, they have a big registry for causes of death in the whole population. So they took a bit more than 7,000 former professional players and checked what they died from. And then they took more than 22,000 males at the same age as a comparison group. And then they checked if some diseases are more frequent than others in one group compared to the other. So the focus was on, is football healthy? Does football lead to some diseases more frequently than in the general population? or possibly the other way around. And the first and a little bit disregarded result of this study was football players become older than non-football players. And this is mainly due to cardiorespiratory diseases and even some cancers being less likely in football players. But what led to the most attention was the hazard ratio for neurodegenerative diseases. What is that? The hazard ratio compares the number of cases in football players with the number of cases in non-football players. If the hazard ratio is 1, or let's say if 1 is within the confidence interval, then there is no difference. But you can see here easily that all these numbers for neurodegenerative in general and for some subtypes of neurodegenerative disease, they are all clearly above 1. And the confidence intervals, they do not include the 1. So their conclusion was, and you can see that from the title already, neurodegenerative disease is more likely in former football players. And based on other analysis of this data set, they concluded that it's most likely due to heading. Because those players who do less heading, for example, goalkeeper, maybe a left winger, they have a lower likelihood of neurodegenerative disease than middle strikers or middle defenders. Well, not so sure if this conclusion is justified, but that's what they interpreted. Of course, such a high rate of neurodegenerative disease is something that no football community would like to have. But it is still a cross-sectional study which only relied upon death diagnosis. And to be really honest, I was the first point that I was asking myself about, is dementia, is it a cause of death? If I write a death certificate, possibly that I write myocardial infarction on it, possibly I write sudden cardiac death on it, maybe whatever, pulmonary embolism, something like that. But dementia as a cause of death is a bit unusual to me. Another point of interest is the number of former soccer players, football players. So almost 8,000. We are currently doing, I don't say a similar study, but a study with a similar design at least, and try to find former football players in Germany. Germany has about 15 times the population of Scotland. And I'd say that football is probably similarly popular in both countries. We really struggle to find 3,000 former professional football players, and they find 8,000. So the population is a little bit undefined. Are these really former football players, or are these possibly football players who get some money? It is also unclear if there might be some confounders involved. So maybe alcohol. Alcohol, we all need, leads to neurodegeneration. Do football players possibly drink more alcohol than non-football players? It's possible. Nevertheless, the result remains and is a little bit alarming. And based on that, a lot of discussion has been in the media. And you may know that in the United States and in the UK, heading has been forbidden in the youngest age groups of football players up to the age of 12. So what did we do, or in this case, what did UEFA do? UEFA wanted to conduct its own studies on that and wanted to have a little bit simpler look on what might be behind this, or if this consequence in the United States and in the UK is really justified. So in other words, should we really forbid heading? And based on that, the UEFA heading study was designed. And as you can see here, that was done not just by our group, but we were the primary investigators. Overall, we had players under 12, under 10, and under 16 from 8 European countries. And the study was relatively simple. We recorded matches on video, we recorded training sessions on video, and we counted the number of headers. And as you can easily see, the median in under 10 was 0. The median in under 12 was 1. And it was 2 in under 16 males and 1 in under 16 females. So overall, in match play, the frequency of headers is really, really low. So if you forbid headers, probably this will not have a big effect on football match play, even at that age. However, during training, we saw much higher rates of headers. So there seem to be training sessions that overdo it. Some trainers, some coaches made their players head the ball 40 times. I don't know that, but I think this is probably not so good for the brain. So then, based on that, UEFA issued some recommendations, not forbidding heading, but giving clear recommendations for training to reduce the number of headers, to possibly play on small pitches, on small goals, and all these measures that may avoid heading. And besides that, take care that a good header technique is introduced with low risk as far as possible. So currently in football, we have 2 different approaches. The header ban approach in the UK and in the US. And the other approach is to try to introduce heading at low risk. And of course, we have countries who don't have any regulations. So this is, I think, the main story about heading. And then possibly let's step into the next one. Injury patterns, because this is also something that affects women's football. You may know, if you're a little bit involved in football research, there is the biggest study that exists is the Elite Club Injury Study, or it was, in earlier times, it was named the UEFA Champions League Study. The study is run by Jan Ekstrand from Sweden, and it exists since 2000 or 2001. So over 20 years now, or more than 20 years, they register injuries in these high-level clubs. And of course, one of the main interests is, do we see trends? Is there some change? For example, if the number of injuries goes up, do we have to do something to avoid that? And one of the most prominent publications out of that is one from 2016, where they have had a look at hamstring injuries. And I think without any statistics, we can easily see that there is a clear increase over time. We have years where it is lower, but overall, the trend is an increasing one. So hamstring injuries probably have become more frequent in modern football, maybe because the game is a bit faster now. You do more sprinting. Hamstring ruptures are a typical sprint injury, but nobody knows what the final reason is. But this is what you can get out of such studies. And as I said, that women's football is a new focus of these studies right now. It is possibly interesting to have a look at another trend. It is a trend in ACL ruptures from the age of 17 to the age of 33. So the dark bars are men and the light bars are women. And you can see that there is a rise up to the mid-20s and then a decrease again. But interestingly, in the women, we don't see a lot of ACL ruptures anymore in the second half of the 20s and in the 30s. So why is that? It is well known that these ACL ruptures lead to the end of the career in many women's football players. So at least the second ACL rupture frequently leads to a stop of training. And so obviously, when you survive until the age of 23, 24, then it's good. But otherwise, there is a high likelihood of the end of the career. And one needs to say that women's football was much less professional in earlier years than it has become in the recent years. So the recording of injuries, as it is done here by means of reports from the medical staff, was definitely not perfect 10 years ago, but it has become much better in recent years. So I think there is a little bit of uncertainty in these data from women's football, and they will probably become much better in the near future. And I think before we go into the discussion, one last topic to address is I would like to go for COVID, because we were all affected by COVID-19, and the infection management was one of the issues that we had to do in all teams, in all leagues all over the world, to be allowed to play under the COVID conditions. And we are still a little bit proud to have been the very first country where we restarted the league with a very, very heavy hygiene protocol. And this has also been accompanied by scientific studies. And this has been published in the British Journal of Sports Medicine. And we were able to show that over the entire remaining season, I think it was 260 or 70 matches, we didn't have a single infection. However, we must mention that this was under the Alpha variant of the virus, so very early in the disease. That probably would have looked different under the Delta variant or the Omicron variant. But then at least vaccinations were available, whereas at this point of time in 2020, we did not have any vaccination against COVID. So no influence from them. And the second, over time, the second problem that arose was then possible consequences for players who were infected with COVID. So here we had very, very few infections. But later, under the Delta variant, which was more contagious, we had more infections. And over time, we finally had almost each player infected by COVID at some point of time. Different variants, of course. Most of the players, even though they were vaccinated, at some point of time acquired an infection. And from very early investigations in the MRI, it was reported that up to 75% of all patients have some involvement of the myocardium. So myocarditis, or maybe we shouldn't call it myocarditis, it is really an involvement of the myocardium. So what they did in this study was putting 100 patients from a clinical population, not athletes, from a clinical population into the MRI, and they really detected some indications for myocarditis in 78 of them. So that was alarming once again. And football leagues and practitioners, medical doctors in football were urged to have a closer look at that. So do we put our players at risk if we let them play football during a pandemic? This question came up a second time. And after a while, some reassuring results came from populations in football or from populations in other sports. And the very first one was, by the way, published in the Journal of Science, Medicine and Sport from 111 Polish athletes. And in these 111 Polish athletes who were not all put in a cardiac MRI, but underwent a comprehensive examination protocol, they found no cases of active myocarditis or pericarditis. So a little bit reassuring, but it took a while until the first big study results were published from the United States. And they were published in JAMA Cardiology. And this was a study in almost 800 professional athletes from the MLS, the NBA, the NFL, and the NHL. And they, once again, underwent a comprehensive protocol according to the recommendations at that time in America. And finally, the outcome was, probably you can't read that, but 3 with myocarditis and 2 with pericarditis out of 789. So once again, this was reassuring because this is lower than 1%. And as far as we know that, you probably can take any virus of the world. And if you have 100 persons infected by this virus, there will be 1 having a myocardial involvement, which does not necessarily mean that this must be dangerous. But if you apply very, very sensitive in examination tools like the cardiac MRI, sometimes you find something you shouldn't find. There is no clinical meaning in it, but you find it. And that is probably, at least this is my opinion, what has happened here. So now we know that the COVID virus it's not completely without danger, but it is probably as dangerous as other viruses for the myocardium. It does not seem to be a higher danger of myocarditis than we see in other viruses. And finally, then we had the vaccinations, and you may well remember the next topic arising was side effects from vaccination. So is it possible that athletes are at risk from side effects of their vaccination? And no, I'm back. Yes, and this is the study on which these suspicions were based. So in an unvaccinated general population, so if you go to the marketplace here, take 1,000 people from Guatemala and put them into a cardiac MRI, you will probably find some myocarditis. And this is what is the expected number. This is not 0. And it is higher, the higher the age is. And then they contrasted this with the observed number of myocarditis, not in athletes, but in the general population. And so you could somehow identify the population at risk. You can see here, the young ones, they have higher values observed than expected, even in the females, but much higher in the males. So based on this study, it was quite clear that the risk population for side effects of an mRNA vaccination was young males. It was not the older ones. It was not so much the females. It was the young males. So typically those players who are active in the highest leagues, these are young males. Once again, the question arose, do we put them at risk? But then after a while, it became clear that this myocarditis is relatively mild. We all have to take into account it's not the form of myocarditis that we usually see. There is no infectious agent entering the myocardium. This is just an autoimmune reaction. So it is an immune reaction elicited by the vaccination and affecting the myocardium. So in most of these cases, in almost all of these cases, it was a short course, mild course, and players were able to go back to training relatively quickly. And if you compare this to the infection, this is a number of possible symptoms after COVID disease and after COVID vaccination. And you can see the yellow bars, no, the orange bars. The orange bars, the Dutch bars, they are for infected individuals, and the blue bars are for vaccinated individuals. And for all of these symptoms, except for one, and this one, except for two, the symptoms were found in much higher numbers in infected individuals than in vaccinated individuals, which means that compared to an infection, the vaccination was definitely not risky. The two ones that are more frequent after vaccination were lymphadenopathy, which is probably not so dangerous, and herpes zoster, which is at least not a big issue in the young population of football players. So once again, this was reassuring. So over the time of the pandemic, we had an up and down, was declared risky, the risk was mitigated, it's declared risky again, and it was mitigated. And I think, although I have not checked my watch now, I think we can end with this, because I hope at least I have illustrated a few topics that we tried to manage over the last years in football medicine, and at the same time illustrated what we are working at our institution. And I've also given you an idea what programs we run for international students. So Susanna, I think we both can then start to answer questions from the audience. What would you like to know? What would you like to discuss?
Ahora hay un poco de tiempo para ustedes hacer preguntas.
Yeah, feel free to ask in Spanish.
Pueden hacer cualquier pregunta, no tiene que ser una pregunta sobre algo específico. Porque usted decía,
I think I can speak loudly. Oh, excuse me. How many days after the infection can players go back? This has changed over the pandemic. So the early recommendations were at least 14 days. However, this was not based on any studies, but just on caution. So we were really careful to send players back. And even then, we made them undergo a very extensive program of examinations. And now it has gone so far down that it is 3 days without any examinations afterwards. So it is very similar to just a regular infection, because for most of the infections before 2020, we did not know what the infectious agent was. We just said it was a virus infection. And then, of course, with a virus infection, you told your players or athletes not to train, but you monitored them for a few days. If they still have symptoms, you possibly took a blood sample, checked for CRP and for the blood count. And if that was okay, you let them go back. So that's where we are now. But in the early stages, it was completely different and it went down.
I would like to know, like, in the head injuries in the sport, gracias. How can we prevent it? Like, for example, in the boxing or martial arts, they're used like, because if I understood, they only use, there are more probable headaches in the trainings, not in the aspect of the competition or the games. But for example, in the boxing or martial arts, they use like the protective equipment. So can we como implementar that type of equipment in the workouts, or like make the ball softer for the head? I don't know. Have like options so prevent it?
This answer may become a bit longer. So in some sports, collisions are part of the sport. So for example, in American football, you can't completely eliminate collisions. Otherwise, the sport would not exist anymore. So it is very difficult to do it there. And the only way to do something is protective equipment. If you look what they wear a helmet, they wear protectors around the body, so quite a lot. On the other hand side, rugby is a similar sport. And you may know what rugby players say about American football players. They typically say, oh, come on, they are really too weak to play rugby. Because they play without much protective equipment. So the sport itself can make a choice, at least in these collision sports. But I don't see anything else than protective equipment, and maybe in training you can do some additional precautionary measures. The situation is a bit different in football. Football is a contact sport, but it's not a collision sport. So collisions happen, but they are not really part of the game. And we are, at this time, we are discussing about heading only for the young ones, because we say, well, if you're 18 years old, you can decide yourself if you want to expose yourself to a risk or not. So the question mainly centers around the children below 12, maybe below 14 years of age. Probably a helmet doesn't help a lot for concussions. The helmet helps against skull fractures, but skull fractures are not our problem. Skull fractures are so rare that there is no need for action against them. At least this is what most of us think. However, concussions occur because there is sometimes a backlash injury, or sometimes at least the head is moved quickly in different directions, and maybe there is even a rotational component within it. So that's not a structural damage, but a functional damage. So what can you do about that? Helmet doesn't help a lot. Of course, you can forbid heading. This is discussed, but I think all people in football don't like that. And the people out of football say, why don't you forbid heading? At least those ones who are speaking publicly. And of course, what we know leads to less functional damage of the brain is having a good header technique. And this needs to be introduced. And you can do that with balloons, you can do that with softballs, you can do that even without balls, by just training the correct movement. Finally, of course, it comes back to match play. And then we need to be aware what is the most frequent cause of head injuries. It's a header duel. So if we forbid heading, we probably not just reduce headers, we also reduce head injuries at the same time. So in that sense, it is attractively appearing solution, but to be honest, I don't see that the football community will quickly arrive at that, because still the problem is so much lower than it is in the collision sports that most football players probably say, well, we tolerate that remaining risk.
So what does a typical day in the life of someone who specializes in sport medicine look like? That's one question. But on a day-to-day basis, what is it that you...
I'm not sure if it is really typical what I am doing. In Germany, it is. But in other countries, sports medicine is completely different. What we need to be aware is, the main factor is if sports medicine is a specialty or a subspecialty or nothing. So if it is a specialty, then you can completely specialize into sports medicine and possibly have your private practice or whatever and treat athletes and nothing else. But if it is a subspecialty, it's much weaker. Then you may have 1 year of education and you are a surgeon who specializes a little bit in sports medicine. If it is a subspecialty, usually there don't exist many sports medicine centers. If it is a specialty, you have sport medicine centers where you really have a number of sports physicians treating athletes. So that is, I think, the first question. In your country, is it a specialty? Is it a subspecialty or nothing? When it does not have one of these categories, probably sports medicine is only integrated into other patients. And only in those countries where it is a specialty, you have centers like ours. Interestingly, in Germany, it's not a specialty, so we are an exemption. So in Germany, sports medicine is mainly existing in university centers because it is only a subspecialty. You won't find anyone, any hospital, any general practitioner, any whatever specialist who in her practice treats only athletes. That is only in universities. But for example, in Australia, they have both. They have a specialty and a subspecialty. You find a lot of practitioners who only treat athletes. In that sense, there is no general answer.
Thank you. I would like to know if, with your experience in Latin America, there is a field of work for sportsmen.
Maybe I can give this to one of you because your experience, particularly in Latin America, is bigger than mine.
Bueno, primero que nada, para mí es un placer estar acá, regresar a estos pasillos. Yo soy estudiante aquí en la Universidad de San Carlos, hace muchos años que estuve acá. Y pues para ponerse en contexto, en realidad nosotros estamos trabajando en colaboración con el doctor Calwa, tratando de hacer justamente esto, esta colaboración para poder crear que esta área científica se vuelva más palpable para nosotros, porque nosotros estamos empezando en esta área. Yo soy médico de la selección de fútbol de Guatemala. Iniciando, hago una invitación para todos los estudiantes que quieran rotar conmigo en la FEDEFUT. Sí, estamos tratando de crear esta vinculación directa con la Universidad de San Carlos. Entonces, esos son los primeros pasos que estamos haciendo acá en Guatemala. Pues tu pregunta particular era si había alguna el mercado de trabajo. Ok, en realidad estamos empezando, estamos iniciando, pues básicamente mi persona, incluso un colega que estaba por acá sentado, no sé si lo vieron, salió, lástima que salió, es un muy buen amigo mío. Estamos empezando el tema de Sport Medicine o trabajando en esta área, porque estaba muy en pañales hace algunos años. En realidad no teníamos espacio para trabajar. Estamos tratando de generar ese espacio y pues ahora yo que los veo por ahí sentados, en realidad me da mucho placer que están interesados en esto. Yo sé que los que están aquí sentados es porque están interesados en esto. Como decían por ahí, no son muchos, pero somos rudos, muchos y muchas, ¿verdad? Porque ahora incluyendo a todas también. Pero creo que va a haber espacio más adelante, creo que va a haber mucho espacio. Tenemos un proyecto directamente con la doctora Susana Crucine, específicamente para trabajar en esta área. No solo aquí en Guatemala, sino que también para que se puedan exportar hacia otro lado estudiantes y áreas de trabajo. Creo que va a ser posible. En algunos años, ahí está el doctor García Mugi, por cierto. Es muy buen amigo mío y justamente le estaba diciendo que pues, somos como pioneros en esta parte de la medicina deportiva en Guatemala. Sí nos ha costado mucho, te repito, ¿verdad? Pero estas vinculaciones con la universidad de donde está el profesor Meyer, creo que nos va a ayudar mucho. Pues en mi tiempo, en realidad, no había esos espacios. Tuvimos que generar pues, un espacio por nosotros mismos, pero ahora creo que va a ser mucho más fácil para ustedes tener esa vinculación rápida, probablemente sin tanta papelería, sin tener que escribir tanto. Yo creo que directamente con la Universidad de San Carlos se va a poder hacer este nuevo proyecto. Y como les digo, creo que ustedes están en un muy buen momento. Me va a alegrar mucho ayudar en estas vinculaciones para que sea más fácil para ustedes y no tan difícil como lo fue en nuestro tiempo. La verdad es que fue muy difícil iniciar con eso. Entonces, pues les repito, va a haber una vinculación, se va a trabajar en este tiempo con el doctor Calva y el doctor Eric Torres. La doctora Susana Crucina nos va a colaborar muchísimo en este aspecto para el trabajo, que era tu pregunta, y pues para el tema de investigación, para el tema de incluso de ir a estudiar fuera. Creo que el doctor Meyer podría ser una posibilidad. En Holanda van a haber otras posibilidades, otras universidades y hospitales, y no solo en esta área. En realidad, este trabajo que se va a hacer se va a extender mucho más allá de la medicina deportiva, no es específico, pero para regresar a la pregunta específica, creo que de momento, cuando llegues, creo que va a haber mucho campo. Actualmente se va a trabajar mucho en el área científica para darle más valor a esta área, porque en realidad nosotros estábamos en pañales cuando iniciamos, pero se va a dar espacio. Y la invitación a corto plazo es que pueden ir a FEDEPUT y hacer este tipo de estudios, o creo que el electivo y este tipo de actividades estudiantiles, ¿verdad? Entonces, no sé si te conoces bien tu pregunta. Y creo que en general en Latinoamérica hay otros espacios para poder estudiar. Hay algunos espacios. Sí, claro, por supuesto que sí.
Buenos días. Yo ando aquí de shooter. La verdad es que cada vez que hago medicina del deporte me van a ver ahí medio metido porque estoy bastante metido en el rollo. Realmente, cuando preguntamos sobre el campo de la medicina del deporte aquí en Guatemala, tradicionalmente vas a pensar en fútbol y vas a ver que la gran mayoría de médicos del deporte van a estar trabajando para el Estado, ya sea para el Comité Olímpico o para la Confederación Deportiva. Es un poquito de desconocimiento del área. Yo creo que el doctor, cuando le preguntaban qué hacía en el día a día, fue muy específico de que eso es lo que hace él en su institución o en el área en la que él trabaja, pero realmente la medicina del deporte tiene muchas áreas, y hay muchas áreas donde puede haber mucho crecimiento. Nosotros tenemos un proyecto que trabajamos de forma privada, que le llamamos la Academia de Deporte y Ciencia, y estamos tratando básicamente de dar a conocer qué es fíjate que no se menciona como medicina del deporte, sino como ciencias aplicadas al deporte, porque realmente son muchas ciencias las que van a converger en un solo punto para, con el objetivo fundamental de mejorar o de llevar al siguiente nivel al atleta o a la institución deportiva. Dicho esto, te puedo dar ejemplos. Yo siempre pongo el ejemplo. Tenemos un amigo de Ecuador que se llama San Martín, que tiene un laboratorio de evaluaciones funcionales. ¿Y qué es un laboratorio de evaluaciones funcionales? Básicamente, pruebas ergométricas para ver el consumo máximo de oxígeno, lactato y la condición física del paciente en términos generales. Y él vive de eso, él vive de asesorar a los atletas para mejorar marcas. Uno podría pensar que en Guatemala esto no es factible, pero luego vengo y te digo que Ecuador es el país de Sudamérica que más se parece a Guatemala, y que este hombre vive de eso, no en Quito, sino en Cuenca, que es una ciudad de 300,000 habitantes. Entonces, yo creo que a mí me encantó esto. Yo no sabía, hasta el día de ayer me enteré que iban a hacer esto, y por eso fue que me vine a meter mis narices. Me encanta ¿cómo se llama? La visión, porque estoy convencido, y es lo que nosotros predicamos en el día a día, que nosotros como país no llegamos a ningún lado, deportivamente hablando, porque somos demasiado empíricos. Y aquí es donde empieza el cambio, en la formación y en buscar nuevos profesionales que puedan llevar esto un paso más allá. Gracias.
Muchísimas gracias a todos por sus valiosos aportes. Tenemos algunas preguntas para nuestros invitados especiales de parte de los asistentes virtuales. Una de las preguntas está dirigida a la doctora Susan Crucina, y nos preguntan que cuáles son las emergencias que se presentan relacionadas a al deporte en la experiencia que usted tiene? ¿Cuáles son las emergencias más relacionadas al deporte?
Okay, thank you so much for the question. Well, I think you know, because most of the time it's the ankle and the knee issues. And of course, what we see a lot is the head injuries or the injuries of the cervical spine. So that's are the most important lesions you see in sports on an emergency room. And especially in the Netherlands, we always try not only to treat the patients who come with these lesions, but always try to prevent. So one day I was on the emergency room and 3 patients came in with a very severe ankle injury and fractures of the ankle from the same football club. And then it's normal, we contact this football club and ask them to come to our emergency room during the week to have this talk. How is it possible that 3 players have this very serious injury? Maybe there's something with the grass or something else going on. So we not only try to treat them, but we always are very alert on maybe some preventive interventions also.
Muchas gracias. Ahora tenemos una pregunta dirigida al doctor Meyer. ¿Cuántos años tuvo que estudiar para dedicarse a la medicina del deporte?
Siete.
Gracias. En las diferentes partes del mundo, el deporte la ejercen diferentes especialidades como traumatólogos, médicos clínicos, médicos con especialidad en rehabilitación o en ergonometría. ¿Hace alguna diferencia a los pacientes estas diferentes orientaciones?
What is the difference? What is the difference? What makes the difference from patients for
Not so easy to answer. And particularly from a perspective of a country that doesn't have sports medicine specialization. But of course, I know what is part of the sports medicine specialization in some other countries. You typically have to go through maybe 1 or 2 years of internal medicine. You have to go through 1 or 2 years of surgery, maybe orthopedic, traumatology. And I think the difference to other specialties is mainly in 2 areas. So the real athlete care, and that is mainly for performance-oriented athletes. And the second one is the focus on sport as a preventative tool, which needs to be dosed like a drug, which needs to be prescribed ideally like a drug. So if you have hypertension, you probably want to have an ideal drug therapy and not just whatever antihypertensive drug. And the same is true if you use sport as a drug. But it is more difficult to decide about sport because it's not just the number of milligrams. It is what kind of sport, how long, how frequent, how intense. And that makes, I think, the specialization of sports medicine different from others.
Muchísimas gracias.
Solo en adición a esta pregunta, en realidad, creo que esa sería parte del proyecto que se debería de concretar aquí en Guatemala. El problema es que la pregunta es exactamente que las diferentes especialidades, estas se dedican a la medicina del deporte. Acá en Guatemala sí tenemos esa confusión, en realidad es una confusión. El profesor Meyer es directamente un especialista en medicina del deporte. Acá en Guatemala hoy por hoy no tenemos especialistas en medicina del deporte. Y ese es el problema, que muchas especialidades, incluyéndome, yo soy traumatólogo ortopedista, comenzamos a abordar ese tema. Y en realidad no debería ser así. En realidad el proyecto debería ser concluir con una especialidad en medicina del deporte, que estaría enfocada también en un tema de medicina deportiva, medicina preventiva, que eso es lo más importante en realidad, tal vez concluir con este tipo de medicina del deporte. No solo que sea una finalidad exclusiva del deporte, sino que para concretar terminar en una salud pública en general y abordando ese tema para medicina preventiva, no exclusivamente del deporte. Y para finalizar con tu pregunta, yo creo que ahora actualmente hay muchos temas como trabajos específicos para prevención de lesiones deportivas. Ahora ya se sabe que ciertas lesiones son por algunas razones específicas. Normalmente lo que tratamos de hacer es fortalecer muscularmente, hablando, el cuerpo para prevenir las lesiones. Entonces, tu pregunta, tal vez para finalizarla de contestar, tenemos en el fútbol, por ejemplo, tenemos algunos trabajos específicos para la prevención de ciertas lesiones, propriocepciones, bueno, etcétera, y tendrías que rotar con nosotros en la federación. No te voy a decir más tips.
Gracias. Había escuchado la especialidad aquí, saliendo de médico y cirujano a los 7 años. Está médico en rehabilitación física, pero ¿vendrá a ser lo mismo de deporte o nada que ver?
Pues es una buena pregunta, muy directa. No, en realidad esta especialidad es otra especialidad. Estos médicos se dedican puramente a rehabilitaciones de enfermedades muy específicas. Claro que abordan un poco lo que es lesiones deportivas, pero desde el punto de vista de rehabilitación. O sea, eso ya llega o es en un momento en el que ya el paciente tiene la lesión. La medicina del deporte va mucho más allá, es antes, es preventiva, es preparación, es encontrar un espacio para estudios, como lo hace el profesor Meyer, en cuanto a buscar ese tipo de respuestas en el mejoramiento del deportista o de la población en general. Es diferente, no es lo mismo. Exacto.
Muchísimas gracias a todos por sus valiosas preguntas. No sé si hay alguna más.
Quería preguntarle al doctor Meyer la experiencia o la frecuencia de arritmias después de tener COVID en los deportistas, si nos pudiera compartir, por favor.
So it is about arrhythmias after COVID. To be honest, no, we don't see more than that. But what we can expect is we have never ever had so many virus diseases at one point of time. As we know that viruses affect the myocardium, and typically arrhythmia comes from that, that it can even be expected that we have some degree of increase in arrhythmia. But what we definitely don't see is an increase in sudden cardiac death. So maybe there is a little bit more of arrhythmia, although we can't see that, at least in my center, we can't see that. But it is obviously not dangerous, so it's not malign, but more benign.
Muchísimas gracias. ¿Está resuelta su pregunta? Ay, perdón. Sí, sí. Okay. Bueno, entonces vamos a agradecerles a los doctores, incluyendo al doctor Errol Méndez, que afortunadamente está con nosotros el día de hoy. Tuve la mala suerte de perder la presentación y no lo pude presentar al inicio, pero muchísimas gracias por estar con nosotros hoy. Y a los asistentes virtuales y a los asistentes en esta aula virtual, les pido por favor un aplauso para ellos. A continuación vamos a entregar los diplomas a nuestros queridos participantes. Los diplomas dicen así: Universidad de San Carlos de Guatemala, Facultad de Ciencias Médicas, Unidad de Apoyo y Desarrollo Estudiantil, otorgan el presente diploma a el doctor Tim Meyer por su valiosa conferencia Conversatorio en Medicina del Deporte. evento realizado en el aula virtual en el Centro Universitario Metropolitano y transmitido a través del canal de YouTube MediaMed, dirigida a la comunidad facultativa Ir y enseñar a todos. Guatemala, 15 de marzo, y el diploma está firmado por el doctor Eric Porres Mayén, que es el coordinador de la Unidad de Apoyo y Desarrollo Estudiantil, y por la doctora Virginia Ortiz Paredes, que es la secretaria académica de la Facultad de Ciencias Médicas. Doctor Meyer, agradecemos muchísimo su valioso aporte el día de hoy. Gracias. Gracias. El mismo diploma vamos a entregar a la doctora Susan Lusing, agradeciendo su valiosa presencia el día de hoy. Gracias a usted por estar con nosotros el día de hoy. Y también al doctor Errol Méndez. Gracias. Gracias, muy amable. A los asistentes, tanto virtual como presenciales, les pedimos por favor que accedan al link para poder registrar su asistencia y poder descargar su diploma de participación en esta actividad. Y a todos los asistentes virtuales agradecemos su paciencia y su preferencia el día de hoy. Gracias a todos, que tengan una feliz tarde.